conference. First and foremost, I'd like to extend a warm welcome to our panelists, our speakers, and to all of you, the audience and our guests. When I was reflecting back, when I was asked to do a session on lived experience, so disclosure, I do not have type 1 diabetes. I'm a clinician by background. I was reflecting back, I've been in diabetes now for 31 years. And a long time ago, what we used to do was go into a room as clinicians, have a conversation about diabetes, and then come in and meet our patients with diabetes and have a conversation with them, which basically went one way. And I'm delighted to say that I've seen that change over the time I've worked in diabetes. Lived experience brings the expertise of life to diabetes. And without the expertise of life, it's impossible to get management right for the individual. And the one thing my time over diabetes has taught me is that unless you have a conversation with somebody and truly understand their perspective on where they are within their life, you cannot truly hope to help that person to be able to manage and live with their diabetes. When you reflect back, you will understand that for somebody living with diabetes, they only ever truly get to see a clinician for a very, very, very short amount of time in any one given year. The rest of the time is spent by themselves, with their family, and with those around them, trying to manage their diabetes. So we have a duty to try and understand as best we can when we have that precious time and to help people to understand diabetes and work in partnership. So lived experience, you can learn a lot about diabetes from a textbook, but you cannot learn about the true impact of diabetes in life unless you speak to people living with diabetes. I'm delighted to say it's changed services now. We look at service design, bringing people in with lived experience so we understand more how people engage with services so that we can gain more and more. And so it's really, really valuable to be here today to have people with lived experience talking about the lived experience that we can change for the future, how diabetes care is delivered into the future. Through doing that, we can hope to address things like stigma. We can hope to address health inequalities, health inequity, and we can understand what it truly is like to live with diabetes and to help people to manage that condition and hopefully, ultimately aim where we do as Diabetes UK for a world where diabetes can do no harm. So thank you for inviting me along. I'm looking forward to hearing conversations today, and without further ado, I will hand over to the speakers.
Thank you so much for those lovely words of welcome, and also for giving me some time to recover from my low blood sugar. I flipped the slides a little bit, but it wouldn't be honest of diabetes to not show up at the most inconvenient moments. As I was saying, dedoc is a platform for people with diabetes to stand on, and basically the goal of dedoc is to ensure that the lived experience of people with diabetes is present in all rooms and situations where those conversations are being had about us. That is why our mantra is nothing about us without us, and that's why today the title of our symposium is What We Wish You Do and Why, which is floating around here lovely in the background. So we have an amazing lineup of speakers today talking about all different points of engagement. So we always struggle to pick out speakers from the amazing selection of dedoc voices. And today we have speakers talking about their experience in advocating in policy and government, their experience in advocating with online peer support, working with the NHS, and working with the Diabetes UK Lived Experience Advisory Committee. So it's really exciting to learn more about all of this different amazing stuff that the people up here do. But one thing I really want to highlight is with the dedoc voices, and especially the speakers here today, is all of these people have full-time jobs, are doing all of these other things in their personal lives, and they're here this week on their own time and their own energy, and they put this into these spaces to make sure that their voices are present. So a huge thank you again to the UK for having us. For me, myself, I'm not sure if the slide's going to move forward, but maybe it will. No? It's okay. For myself, I started off as a dedoc voice 2 years ago, and basically have become the head of the programme in the last year, and it's an absolute privilege to be on this side of dedoc, supporting all these amazing people to come to conferences the way I've had the privilege of doing so. So without further ado, I will introduce our first speaker, Alyssa Faulkner, who is an avid netballer, project manager for children's charity in Scotland, and an amazing advocate. Thank you, Alyssa.
Not sure if my slides are going to come up, but I'll just get started introducing myself. So, hi everyone, my name is Alyssa Faulkner. I have a diabetes persona called Pumptastic Scot, and I want to talk about driving healthcare change and doing advocacy from a lived experience perspective, using a personal touch, and I'm going to talk about some of the campaigns that I've been involved in and some of the avenues that we used to drive change in them. I think it's working. Perfect. I have no conflicts of interest to disclose. Okay, who am I? So I've lived with type 1 diabetes for 11 years, since 2013, and I have been a diabetes advocate since 2014. So I very early learned on my diabetes journey that I wanted to help make that change be the change that I didn't see in my diabetes care. And so my journey in diabetes has grown in diabetes advocacy. I started off getting a bachelor's in community learning and development, where I focused on youth work, because I felt like working with people was my strength. And then I went on to get my master's in social justice and community action, because I felt like as a diabetes community, collective action is one of the most important things that we have in our pocket. I currently work in my professional life at a Scottish children's charity focused on children's rights, and in that we work with the Scottish Government and Parliament to make change for children and making sure that every child has their human rights that they are entitled to. Where I'm a project officer, not a programme manager yet. And I write a blog called Pumptastic Scot, which is a diabetes blog focused on my lived experience. It also looks at what is happening in the diabetes world, projects and new technologies and innovations, but I also invite guest bloggers to come on and share their story in diabetes. And a few years ago, I created an event called Young Fun in Type 1. It was for young people aged 16 to 30, and that was a project done in conjunction with Diabetes Scotland. And they were invited to just an event with learning and fun things, and it was a free event to attend as well. Okay, on to advocacy. So I wanted to talk about a couple of campaigns that I've been involved in and how we went about this. So the first one is the Diabetes Tech Can't Wait campaign, which I was involved in previously. This is a Scottish-based campaign, or was when I was involved, and in that this was ran with Diabetes Scotland and a collective action of a group of people with lived experience of diabetes. And in that we used lived experience voices to advocate for access to technology, in particular hybrid closed loops. And in that we shared lived experience stories from people living with diabetes. We contacted our local MSPs, we contacted the press, and we went along to the Scottish Parliament and advocated our politicians, including Jenny Minto, who was here yesterday. And we ended up getting a pledge of 8.8 million, which helped with the onboarding of people in Scotland onto diabetes technology. My colleague Kirsty will talk about more of the onboarding process that she's involved in, but it was a small step into the ongoing battle for access to this vital technology, and that was done through collective action with support from Diabetes Scotland. Another one I was involved in is called Think Check Act, and this was a few years ago. And this was about making sure that inpatient care for people with diabetes is safe. So in that one, I was involved in sharing my personal lived experience story. You can see there's a video of me at the bottom. I had a minor operation on my foot, and when I was an inpatient in hospital, my care left me in a very dangerous situation because of my diabetes. So I shared this story, and this went to Parliament, and it actually got policy change for people living with diabetes and inpatient care in Scotland. So it shows how lived experience voices can make campaigns so much more powerful. It's not just statistics on a page. You can see the real person that will be in a dangerous situation if these things are not fixed. The next one is an old project, but I thought was very fitting, and I would just like to mention. So this was made with Diabetes Scotland again, and I was in part involved in making it. But it's a toolkit essentially created by young people and healthcare professionals in Diabetes Scotland to support people accessing diabetes clinics and not disengaging, and making sure services were tailored to children and young people, and to help education support children and young people effectively. And this was then rolled out, and young people in the youth project then trained up some clinics in Scotland into how to effectively engage with young people so that they get the care that they deserve. And I wanted to mention this. I feel this is a form of advocacy because it involves the end users of a project or of a service from the start. It means that throughout their care, they know best. They're the ones going to be receiving this care, and if at the end it doesn't work, it's then so much harder to go back and start making a change. And so I thought that was a great thing to mention. I also want to say that I have been involved with Diabetes Scotland and UK for a while, but then I'm working with highly motivated people who are already engaged in the diabetes world. An example of this is with the Youth Project in Diabetes Scotland, and most recently the Together Type 1, and also JDRF. But that being said, there is ways to do advocacy outside of working with diabetes charities. If I am doing advocacy for diabetes, working with local charities that can raise the cause bigger. So I worked with Young Scot, and with them I went to the European Parliament, you can see there, and we spoke about how to involve young people in services that affect them in the long run. So with them I was able to take the message further. And with Voluntary Health Scotland, we talk about mental health of people with chronic health conditions. So although it wasn't directly diabetes, it does impact on people with diabetes. And with the Young Women's Movement, charities like this often give platforms to people who are doing work already. So they gave me a platform to share about diabetes advocacy. And if you aren't involved in advocacy yet, if this is something that you want to do, there are ways of starting small. And by sharing your story, it's not always appropriate. It's not always lived experiences are powerful, the voices are powerful, but this has to be done in a very tactful way, in a way a person with diabetes approves of, and so there's different ways to do this. So as I said, I have a blog which I've been doing for 10 years called Pumptastic Scot, but you can contact local media, you can email your MSP, you can do it visually with videos, which we did in the Think Check Act campaign. You can do it on Instagram via pictures or other platforms. And you can also give presentations. So I've given presentations at the Scottish Government and Parliament, at different conferences, for example this one. But advocacy isn't just about sharing lived experiences. As I said, I think having people with diabetes voices included in the project from the start means that it will ultimately be a better service at the end. And I just wanted to say that this is an ongoing thing. Every single step forward means that it is amazing and should be celebrated, absolutely. Like the Diabetes Tech Can't Wait campaign, we did get an 8.8 million pledge, but it isn't the end. Things need to keep going, and it can be disheartening to only see small changes throughout your advocacy journey. But in my 11 years of doing advocacy, I have seen massive steps made, and it is possible to make these changes. So keep going, use your support networks, and keep consulting the people that, for me, like my current dedoc voices, that are going to be using the products at the end, to make sure that you're still doing it correctly, because as generations evolve, as technology evolves, as research evolves, things change. And this is me. Here are my social medias if you want to follow me, and here is my blog website. But thank you very much for listening and giving me this platform.
Thank you so much, Alyssa, for driving home that message, as well for those who are watching from home, as what is wonderful about the dedoc symposium is that it's live streamed from every conference. So one thing I didn't mention at the start is, as dedoc Voices, we attend so many conferences around the world, and at these conferences our session is the only session that is live streamed from the conference without any paywall, which means that people in the diabetes community can also watch. So thank you for an amazing message to drive home to people who are thinking about getting involved in advocacy and those steps that we can all take. Next up, we have the amazing Kerry Louise, who will be speaking more about the advocacy of it within the online sphere. So as dedoc is the diabetes online community, this is very on theme with what we do and what we drive for. So thanks, Kez.
Oh, I'm really tiny, sorry. So today I'm going to talk about navigating a diabetes misdiagnosis and online peer support. So I'm Kez, I'm 36 years old and I'm from East Kent in England. My day job is that I'm a children and family social worker. My type 1 diagnosis didn't come until 2019 when I was aged 31, and I started hybrid closed loop in 2022. It was quite a long journey to get my diagnosis, and I'm going to talk a little bit about numbers, but not as we know them. So when we think of numbers, we think about blood glucose levels, HbA1c, and those sorts of things when we're in clinics. But these are the numbers that are important to me. Number 3 was the number of GP surgeries that I went to before I was listened to, and diabetes was considered as a diagnosis. 6 was the number of hospitals that I approached for support to try and find out why I had been unwell. 3 counties was where I'd travelled between to try and find out again why I was so unwell. I'd had 5 referrals for DBT or CBT because I was told that I had health anxiety. Consideration wasn't given until I was 22 to a diagnosis of type 2 diabetes. After that was considered, I was told that I was too young for type 2 diabetes but too old to be type 1. Throughout that journey, I had some signs that should have suggested to people what was going on for me. I was always tired, thirsty, needing the toilet, and just generally exhausted. When I was approaching healthcare professionals, it seemed like things were being turned around on me and that there was something that I wasn't doing that I should be. It was actually a mum of a type 1 girl aged 11 who had first suggested me that type 1 diabetes might be what was going on for me, and she'd asked whether any tests had been done to see if that was the case. As I said, I was 31 when I was diagnosed with type 1 in 2019. The most important number for me is the number 1. It took just one person to think outside the box and realise that there was something else going on. Outside of the peer support from this mum who had a type 1 daughter, the person who thought outside the box for me was a GP practice nurse who had also worked in the community as a DSN. And that one person gave me the answers that I'd been looking for, and a sense of relief actually, to know what was going on. I travelled to Tunisia in 2019 on a mixed insulin and set doses 2 weeks after my diagnosis. But then COVID hit. It was really tough during COVID for everyone, as there were no face-to-face appointments, and I didn't receive any formal education until 2022. The same nurse who had considered that I might be type 1 also considered that there were other ways of accessing support online, and they told me about Team Diabetes 101, which is a team of multidisciplinary healthcare professionals in diabetes, providing education and signposting to accredited information. I learned a lot from being linked in with that group of people. I could see what other diabetics were asking, and I could interact as much or as little as I wanted. I learnt about sick day rules. I learnt how to find information on carb counting. And I loved that actually the healthcare professionals had Yay of the Day, which celebrated small wins for people who wanted to share their experiences. Despite not being able to see someone face to face, I still felt part of a community. It was the Team Diabetes 101 who led me on to interacting with the GB Doc Info and GB Doc Tweet Chat, who host information sessions each week about different topics by people who live with diabetes. That then led me on to Diabetes Chat, and I think it was around one of the World Diabetes Days, speaking with a group who were present and actually realising that they could provide me with more information about how to advocate for myself, as I was using injections still and struggling to manage my levels without doing up to 14 injections a day. Each of these forms of advocacy and peer support hold one thing in common, and that's connection. Sometimes just having someone to talk to about the highs and lows really makes a difference, and it also helps me knowing that my DSN is also a type 1 diabetic. So I feel confident in going into my clinic and talking to her about things that someone who doesn't live with that experience might not have. These platforms can be used to break down barriers, and for some, can make conversations more accessible. It doesn't just break down the physical barriers as it did in COVID, but also, like with Diabetes Chat, professionals are always welcome to come and chat with us and share their experiences and tell us about what they're doing in their communities and clinics, and share that with people around the world. It's places like this and through the dedoc community that help us to learn and support each other. My hopes for the future are, firstly, that I'd like to see exploration of early diagnosis of type 1 in adults, and early education following diagnosis. I'd like to see healthcare professionals interacting with peer support once diagnosed, and I'd like to see local champions working with local clinics to support local people, so that perhaps someone in my community might not feel alone like I did. Thank you.
Thank you so much, Kez, for sharing your story so powerfully and so beautifully today with everyone here and at home as well, watching. I loved what you were saying about your DSN and about that relationship that you have with her, and that she also lives with diabetes. And speaking of DSNs, our next speaker, Bethan Mair, her daughter lives with type 1. And she'll be speaking on that today, and about her role as a type F, which is friends and family, if people aren't familiar with this. So anyone in this room, if you feel like you are outside, I know David mentioned you don't live with diabetes, but you are type F also through and through, which is friends and family. So I'd love you to take that word home and use that if you're not currently. But Bethan's daughter, who lives with type 1, is out doing some activities today with her DSNs, and she'll share more about that in a minute. So I'd love to welcome Bethan Mair up to the stage.
Pnawn da, diolch yn fawr iawn i chi am y cyfle I ddod I siarad yma. Good afternoon, and thank you very much for the opportunity to come and talk to you here. As you will have guessed, I'm from Wales. So, that going to go on its own? Oh, it's a mouse, sorry. Are we? So our case history, I suppose, is fairly typical, daughter diagnosed at 11. But we like to talk about intersectionality, don't we, these days? And I am a behaviour analyst and a speech and language therapist, so I'm interested in what language means. I'm interested in behaviour change. So in a grim sort of way, I thought it couldn't happen to anyone better than me. But I also knew the limitations of the National Health Service because I was part of it for 18 years. I work independently at the moment. So that's where I came at this. Now, I was at a diabetes, of which I'll talk more later. I was at a Diabetes UK event about 8 years ago, and the wonderful Partha Carr was talking, and he put up this model, which I think works incredibly well. In fact, the slice of time that you spend with your healthcare professional is too small to even show up on that chart. But I figure it's 3 hours in a year, 8,757 hours. So that really resonated with me and stayed with me. Now, there's my daughter Seren looking rather bemused with a battered jug. That jug is the jug that we used when we came home post-diagnosis to measure things. And that jug always made me so sad. It made us feel so weird and alone with this horrid little jug. My family never knew why I kept this weird old jug. And it was only when I asked my daughter to have this picture taken that I admitted it, hence that kind of rather confused expression on her face. But the jug reminds me of where we were weird and alone to where we are now with lots of friends and a big community and making the best out of this. So straight away I got very involved with Diabetes UK and have been for 12 or 13 years on a variety of projects encompassing giving very basic legal advice to parents about their rights and a Good Care in Schools award, which was a very productive thing to be involved in to celebrate the positive. And my friend Alan Macmillan, retired dentist, is there in the back, and he and I have done that together. So nice to see you, Alan. And then that gave me a lot of confidence to look into the way things were run. And this is where I really must give a big shout out to the former retired director of Diabetes UK Wales, the wonderful Di Williams, who was able to show me what needed to be done, what should be done. And I wouldn't say I like a fight, but I like a challenge. So it took me through digging into a lot of what, I need to be diplomatic here, what the Health Board claimed to be doing and what they were actually doing. The outcome of that was £850,000 more funding and 2 extra DSNs and all paediatric cases going straight on to the glucose monitoring systems. Now, I also supervise postgraduate students, so of course my interest in behaviour change was really relevant, and one of my students became trained to be a behaviour analyst like me. That was why I was supervising her, and this is the title of her MSc thesis, as you can see for yourself. Now, this young lady, who also lives with type 1, then went on to become a brand ambassador for one of the continuous glucose monitoring devices. So some of you might be familiar with her name. So I felt that being involved with Diabetes UK, I was on a bit of a roll. And as I said, it gave me the... am I back on that slide now? It's been a long time since I did a presentation, as you can see. Right, there we are. So in terms of my sense of involvement and empowerment, it's really helped me in an awful lot of ways. And I really must give a shout out to the wonderful Leslie Challoner as well, who was a support worker in the Northwest who ran the projects that Alan and I were involved in. It made a real difference to have her. And felt that, you know, like they say, you have a voice at the table, was invited to be on the Diabetes Lived Experience Committee, and hope it's really nice to see you here and other friends in Diabetes UK. And we go down to London twice a year in person, and then we meet online. And you all know who Colette Marshall is, but I want to give Colette a real shout out. When you go to the meetings, Colette's not like so many CEOs who sort of parachuted in from one big job to another. Colette's there in the kitchen, washing up, you know, boiling the kettle. She is absolutely great. And my involvement with diabetes has given me so much. I'm a pretty confident person, but it's given me so much knowledge, so much empowerment, so many opportunities to use what I know to really help, and made me have a very large team of friends and allies. As my daughter's got older, she's 24, I've needed to step back a little bit. But I wanted her to find her own way, and I know the wonderful people from Together Type 1 are here, and she's involved in that. And a big shout out to you for all you do. And I would say to you all as healthcare professionals, in terms of how little time people spend with their healthcare professionals, I think the most powerful thing you can do is to encourage people to go elsewhere and look for support. And be very honest with people, say, I can't do it all for you. My field is challenging behaviour and autism, and that's exactly how I work with my client group. I tell them of the things that I can do, I'm honest about what I can't do, and I say there's so much out there, you need to go and find it. So we were very frustrated when my daughter was first diagnosed, because we found that the DSN was not alerting people to support groups. And I'm not blaming them for that. They were incredibly busy, they didn't have time. But all it took was a simple checklist that, have I given people this, have I told them about this? Most recently, my involvement with Diabetes UK, I had a very distressing incident. My daughter, during lockdown, had a seizure, fell, had a head injury, the kitchen was on fire, so everything that could have gone wrong did. Ambulance turned up, very unsympathetic paramedic, and he said, you're not going in the ambulance with her, we'll deal with this. And I was like, I'll be lying on the road and you will have to wheel over me before that happens, because I know that you can't cope with a CGM and a pump. And that led to me having a meeting with some quite high level people in the Ambulance Trust. I think there's a big amount of work that Diabetes UK could actually do there in terms of advocacy in ambulances for people who aren't ill, but there's a lot to be done. So Di Williams was such a big influence on my life, from Diabetes UK. Leslie Challoner, as I said, Type 1 Together is making such a difference to my daughter at the moment. And I also wanted to pay tribute to our retired paediatrician, Dr. Anthony Cronin, who said this to me. And I remember my husband and I, a lot of you, when you come home with a newly diagnosed child, it's like coming home with a new baby again. And at that time, when I thought I started hyperventilating, when I realized I had to learn how to carb count and nearly fainted at the sight of an insulin pump, I think of how far we came and how comforting Dr. Cronin's words were. So I feel I'm in a room full of friends. I feel in the world of diabetes, I make more and more friends every day. And my daughter was. And Diabetes UK, you have just been absolutely tremendous. So thank you.
Thank you so much, Bethan, or Gurv Míle Magat. You've inspired me to use my Irish. Thank you so much for that incredible presentation. There's so much food for thought there. I just want to remind everyone that, well, not remind, but tell you for the first time, because my hypo did not let me tell you at the beginning, we will do a Q&A after our final presentation. So if you have questions, please get them at the ready to come up to the microphone after this last presentation. And I will be either moderator or referee, depending on what the questions are. And we might get some from our live stream also that my team are going to send in to me. So I might read some off my phone up here as well from our international audience. dedoc is an international community of over 400 alumni from over 100 countries. So you will also be competing with the online space for questions. But without further ado, I would love to welcome Kirsty French, who is going to speak on being a peer support worker with the NHS. So the theme of all of our presentations is basically integrating lived experience into all these different spheres. And with our final one, this is about how it's already been integrated into the NHS in Scotland. And my own disclosure is that I'm also a peer support worker with Kirsty, as well as the head of program for the dedoc Voices. You will notice with any of the voices in this room, they are wearing multiple hats. And after Kirsty's presentation, I'll ask them to stand up so you can see them and network and engage after this session. But without further ado, I'd love to welcome Kirsty French. Thank you so much.
I was utterly convinced I was going to fall off or on one of the steps there, so hyper-focused. So my talk is about enhancing hybrid closed loop onboarding and the NHS approach to peer support. So let's just figure out how this works. That was easier than I thought it was going to be. So my name's Kirsty French. I'm 32 years old. I've had type 1 diabetes for 31 years, so all of my life I don't remember anything different. I live here in beautiful Glasgow, and my day job is in pensions administration, which sounds dull, but it's a lot of like problem solving, complaints, maths. And I've been involved with different diabetes organisations my whole diabetes life. I was diagnosed in October, and we were at a DUK Christmas party that year, so my whole life. Different aspects as well, so peer support, advocacy, the campaign that Alyssa mentioned, Diabetes Tech Can't Wait, I was involved in that, and I love going along to the events and doing volunteering at those. When I was diagnosed, I was the youngest or one of the youngest people in Scotland with type 1, or so I have been told. I do not have the facts to back that up, it's just what my parents have said. And I'm employed on a bank shift basis with the NHS Golden Jubilee as a senior support worker. So my diabetes journey is probably the same as many other people's. From between 1993 to 2019, I was on multiple daily injections and predominantly used just a standard blood sugar meter. In 2018, I got a free sample of a flash monitor, and then started self-funding until it got on prescription, which was nice. Started to pump in 2019, just before the pandemic, so just as I was coming to terms with it, I was trapped indoors and well, let's not talk about that. And then started hybrid closed loop in June of 2023. That my kind of onboarding consisted of one clinic appointment, which lasted maybe about 2 or 3 hours, with 4 other people, and the rep was talking about the system, how you use it, the different features. We put the pump on, and then a week later there was a video call to switch on the sensor and start looping. I couldn't make that call, so they just emailed me and said, if you're comfortable just turning it on, you can. So I did. And that was kind of it. So it's very different with the national onboarding team. So their goals are they want all the participants to onboard safely. They want them to learn to optimise the features of their device and remember that it's their device and they can use it the best way for them. And want them to feel empowered and have the confidence to make those changes without having to consult with their team. Of course they can if that's where they feel comfortable, but they've been given the tools to manage their own diabetes, teach a man to fish type vibe. So how do we get there? What does that look like? So it's a 4 to 6 week programme with, in my experience, between 4 and 8 participants. I have seen ones with up to 10, but that's generally 2 groups put together. Each call has a senior educator present, and they are fantastic people. There's not many of them. I think there's 2.4 in total, and they are fantastic people. They have supplier-led sessions, so that is when a rep from the company will come in and talk through all the different features of that device, teaching people how to implement that into their daily use rather than just reading a manual, because if you've seen those manuals, they're big, they're bulky, you can never find the information you're looking for. There are open sessions that are dependent on the concerns of the group's education, their background, what they want to learn. And the peer support workers come in the last week where we kind of talk through everything they've learned, go over some scenarios, and we give them kind of our opinion on things. It's all participant-led training. It's not a set structure. It is, as I say, dependent on the kind of appetite and education of the group. And it's wonderful. So we teach them how to find their own solutions to problems rather than saying, well, you should do this, you should do that. It's, what do you think? What do you think is the right thing to do? And then they come to the decision themselves, again, giving them confidence in making those changes because they've done it with assist. The onboarding team, so they're not clinically responsible for the participants. They're given the information and everything is fed back to their home team, who are the ones that are clinically responsible for them. And I think Brian gave an updated figure on this yesterday, but the figure I was given a few weeks ago is that between July 2024 and March 2025, there's been 1,089 people onboarded, and the target for the year was 1,000, so we're over that, which is incredible. I've got another slide here that just shows the pathway kind of more officially, rather than me just talking about it. So you've got your patient, it's too small here, too big there, patient identification and referral, and your different things. You can just have a read of that, because I'm struggling a bit to read them both. But it's good, so we've got the different pathways here. I think that's quite important. So some of the people are already on a pump and they're just getting the addition of a sensor that can look with that. Some people are already on the sensor and then they get the pump that goes with that. Some people are completely new to both of them and it's entirely overwhelming for them, and some of them are upgrading their pumps. So there's a wide variety of different people that can come through the system. It's nice. So what we cover, or what the senior educators cover, go through the device type and the functions with the suppliers, look at unexplained hypos and hypers, and talk about strengthening and weakening your ratios, the timing of your insulin, so when best to pre-bolus, things like that. Go through carb counting. I know we all think we're really great at it, but let's be honest with ourselves, sometimes we're not. Talk about the different algorithms, how they work, what they work from, travel, your grab and go bag, or that says grab and go back, so just ignore that. Grab and go bag, which I'm sure anyone with type 1 in the room has on them. Do we have our grab and go bags? Congratulations. Talk about sensor longevity, so timing your changes and things like that. Skin irritation and the logistics of having diabetes rather than the actual management of the condition. So some of the sensors are a bit clunky and fiddly. Talk about how best to tackle that. And if you're anything like me, I think about these stickers and I come out in a rash. So the ones that I use and how I tackle that. Talk about sports modes and the different device ways to reduce your targets. How to switch back to pens, which I think has been really beneficial for me learning this, because if like a year ago you'd asked me how to do it, I would probably just have cried. But now I've learned how to switch back to a pen from a pump if my pump breaks or something like that, or if I just need a break. We go through different scenario examples and red flags to look out for. So if your blood sugar is 14, why is it 14? Do you need to change things? What's going on? And how to deal with that. And again, the information covered is dependent on the group. Now, how does the peer support worker fit into that? So what I do is I'll tell them my background, kind of like I've done today. I'll tell them the system I use and how I felt when I first went closed loop. We have kind of informal conversations about burnout and learning to trust the system, which is a huge undertaking. We talk about different tips and tricks we've learned about the sensor application, sticker skin issues, as I say, how we handle exercise, drinking alcohol, travel, eating at a restaurant, if you've got like full day events, how you deal with that. We just answer questions. People come up with questions that you would never even have thought of. And I think the most important thing is that you're honest with the participants and you don't judge what they're asking you. I think it's incredibly brave to ask a stranger a question. So, like, fair play to them. It's very impressive how honest some of these people are. Now, why do I think peer support is important? So it bridges the gap between healthcare professionals and participants. This is like, I feel like this is specifically important because if you've been a child or a young person with diabetes, there is a tendency for your clinic appointments to feel like school, like you're getting given into trouble. It's not the case. So it kind of gives somebody that's on your side, if that makes sense. It encourages honesty with the healthcare professionals, so real issues can be addressed without fear of judgment or shame, which is very important. So if somebody's doing something with their pump that could cause an issue, it's important that that's discussed, and if they're still going to footer with it, let's say fake carbs, we all know that one, it's important to kind of teach them the consequences of that and how to do it safely if they are going to do it. It reminds them that they're not alone and it is okay to struggle. even if you are going on to this closed loop system, which is wonderful, it's an incredible thing to happen, it's very overwhelming to do that. And we understand the frustrations that the participants might be facing and can empathise in a way that someone without type 1 just can't. And because we're their peers, we can talk to them differently. So it's my favourite one that always happens is someone will ask a question, the educator will answer it, and then be like, Kirsty, what do you think? And I can put my foot down in a different way that isn't telling them off. And it's quite fun to do that. So, what I wish I had been told, and therefore what I tell others. So, how much the system does and how little you actually have to get involved. And whenever I do get involved, something goes wrong, and I am humbled. Because I don't know more than an algorithm that is designed to keep me alive. It's okay to be overwhelmed by something good. As I've said, very overwhelming. It's okay to struggle with that. It takes time. Learn to love it. But you might still have issues. This might not fix all your problems. New problems might arise. You are a person at the end of the day, and people are unpredictable, especially bodies with diabetes. The clinic team are there to help you, not to tell you off. They are nice people. They're not scary. Well, mine aren't scary, and these ones aren't scary. Even learning to trust your system is very difficult and crucial to success. And there's more to life than time and range. I've recently learnt the phrase, whose phrase was it, Jean? Camille said, time and happiness is more important than time and range. And I just think that's beautiful. And my final thoughts. So, I've always had the best diabetes team. I had a great team as a child, which went on to a great team as an adult. Brian Kennan has been my consultant since I was 15, 16, so I've had a great time. But I'm still hesitant to be open and honest with them, and it comes from that fear of getting given into trouble, which is difficult to tackle. It's a very personal thing. But I think having someone there, as I say, on your team really helps that, and helps even the playing field a bit. It can be a bit scary to sit in a big doctor's office and be honest and know that you're going to be told, well, you shouldn't do that. It's not an easy thing to do, so it's important to encourage people that that's okay. They won't give you any trouble. I really wish there had been peer support available during my onboarding, just to explain that, yeah, it's overwhelming, that's okay. You're not doing anything wrong. You don't need to feel guilty. It's okay to be overwhelmed. This peer support format feels essential to the future of diabetes care for me, and I hope it continues with the onboarding programme. And I believe it would be beneficial for other chronic conditions as well, just somebody else to be there to talk to you, kind of like an agony aunt. And I really enjoy working with the onboarding team. Anytime I leave the sessions, I've got a smile on my face, I feel confident, capable, clever, and that my suffering is worthwhile because someone else can learn from it. So that's all from me. Thank you.
Thank you so much, Kirsty Gurvia Malgot, for an incredible presentation talking about the peer support programme with the hybrid closed loop onboarding. It's a really, really amazing programme, and if you want to learn more about it, definitely ask Kirsty some questions, and there's a whole team behind it of incredible people who are making sure that this happens. I would love to welcome questions now. If anyone would like to come forward to the podium in a second. Apologies, those are questions online. But before I do, one thing I missed at the start that is very important to every dedoc symposium is for the dedoc voices to please stand, just to turn around and wave to let people know that you're here if they'd like to network after. Thank you so much. Amazing. So if there are any questions, we would love to hear them. And I might kick... Oh, sorry, yes. Oh. Well, I might kick one off firstly, and my question is for Bethan. For the DLEA, what has been, do you think, the most impactful part of joining it so far as a type F?
Is this working? Can you hear me? Yes, great. Yes,
that's an interesting point. I wanted to first of all, and I forgot to say this, that what was really great prior to me getting involved in diabetes, going to diabetes events, you know, the family information days, the residentials were just absolutely amazing. At one stage, we lived in Botswana and we were on a very expensive safari, and all my daughter could think about was getting back to a wet field in Milton Keynes. And we were like, what? But that's how much it meant to her. So in terms of when you're involved with DLE, Diabetes Learned Experience Advisory Committee, you're a mix of users and family and professionals. And what Diabetes UK essentially do is they run everything past us, everything that they plan. So in this conference, you'll have heard a lot about language and stigma. Those have been discussed at length, things like the collaboration with Slimming World, you know, what people think of that. So you feel very much part of it. And like dedoc, they always look after us very well, and we have a nice time and go to London and have a nice lunch and just have a super time. But apart from that, you really do feel that you are at the heart of everything that has been done. And it's tremendous to be involved with that. And I know that DLE are on the lookout, aren't they, for new candidates? Hope, yeah?
Thank you so much, Bethan. We have a question there from Emma.
Yeah, hi everyone. My name's Emma. I'm also one of the dedoc voices, and all four of you have shared incredible examples of why it's so important to involve people with lived experience in any diabetes work. I just wondered if you could all give me what would be your top tip for anybody who's in the audience who works in the diabetes space, who's now inspired to involve people with lived experience in their work.
I think the most important part is don't be scared of us, we're just people. We know that everyone starts somewhere and everyone has the best intentions. No one comes into this thinking, oh, how can I harm these people? Everyone wants to do their best, and everyone, we are there to help, and we will tell you what we think in the best way possible, and just listen to us and do what you can.
I think I'd say, as I said, it's breaking down the barriers. So there's no harm in contacting, I don't know if Tom's still here, but I can't see him, contacting Diabetes Chat and coming to speak to us about how we can support, or just asking people that you're seeing in your clinics if they're interested in supporting other people. You know, people will volunteer their time, they just need to be given the opportunity.
I would second what I said earlier, which was I'd really encourage healthcare professionals to say to people, you need to go out there, there's lots going on, and there's more than you could possibly get involved in. And also to say to people constructively, you might not agree with a lot of the ways that we're doing this, but the way to change that is to become involved. And certainly again in my field of complex learning needs, all the changes that have been brought about in special education and provision have been driven by parents. And that was a really important point that Di Williams made to me. Change does not come from professional organisations or healthcare professionals. It comes from service users. And I would get frustrated. I would understand why. But a lot of keyboard warriors on these support groups who like to have a whinge. But will they turn up to a coffee morning or give their children a chance to play together and see other children and normalise the regimes that we go through? So you have a huge job in that respect, the healthcare professional, in involving people.
I would just echo what the others have said as well, actually, that if you're a healthcare professional and you see a need for peer support in whatever environment you work in, then approaching one of the charities and asking them, because I'm sure they'd be willing to help you. Maddie's nodding, so she'll sort you out. And there will be people willing to help. We love it.
Thank you all. Thanks, Emma. And I would just love to signpost our symposium from last year at the DUK DDoc Symposium, where Emma actually spoke about meaningful engagement in research. And we had another speaker talking about a meaningful engagement actual document that's been put together by people living with diabetes. But I really agree with all of your comments there about not being afraid to approach people. And I think one thing that I heard that was really interesting at the Cochrane colloquium, they were saying, you know, if there's an issue with the statistician in a research project, you know, it's not said, oh, we'll just get rid of the statistician. But sometimes with involving people with lived experience, if there's challenges or different ways of communicating, sometimes there can be a bit of an inclination to say, look, we'll just leave it out this time, it's too much hassle, but just to be prepared for those challenges and to navigate that with people and keep the communication clear and open for everyone to be involved. Do we have any other questions? Yes, Jay?
Hi, I'm Jay. I've lived with diabetes for 31 years now, and I'm an advocate in diabetes, know a lot of the people on stage. I was really interested what dedoc has done more internationally than just within the British Isles. I'd love to understand a little bit more from you all. What have you learnt that's common between different countries out there in the advocacy world in type 1 diabetes, and what are the things that may be a little bit different, or things that may have surprised you from working with advocates in different countries?
Thanks, Jay. That's a really hard question. I think I've been to a couple of the international conferences before, and there is a lot of similarities. The main similarities is the need for peer support. We all just go to these conferences and bond together immediately, because living with diabetes, any type of diabetes, is hard, and there is a lot of emotional and psychological things that come with that other people in dedoc just understand, and we just like play off of each other. And I think it's something that I have seen as I obviously come from Scotland and the UK, and we are in a very privileged position to have universal healthcare, and so we have access to, on the whole, to the things that we need. Every country is different, so I have learned so much about what we have in this country that is working and perhaps not working, and what in other countries that they have and don't have, and that has taught me a lot about being grateful for what we have, potentially how we can change it to emulate other countries, and perhaps how we can also share what we have going on with other countries to help them. But yeah, thanks for the question, Jay.
Thank you so much, Alyssa. I think Alyssa is actually our only alumni on the panel. Everyone else is a new dedoc voice, which is fantastic. So I'll speak a little bit more into dedoc and an international space. Not to reference the hypo again, but to reference the hypo again, it stopped me from actually sharing a little bit more about dedoc at the start of this symposium and the conferences we do attend. So we started off 4 years ago with 3 conferences, and this year we are doing 10 conferences. So we started off mainly in Europe, and over the last 2 years we've grown to going to America and to Asia. So we were at HD Asia just before Christmas. We were at Diabetes India just 2 weeks ago. And I think what's been really interesting from my perspective, having been a dedoc voice previously, to then coming into the side of things of organising the programme in international spaces, is really opening my eyes to the different disparities and the different needs in different contexts, and just being really mindful of that. I know in this space, for example, we talk a lot about technology and about the barriers in accessing technology, whereas in other countries the challenges they're facing is accessing insulin and the barriers in accessing safe and affordable insulin. So I think what's been really eye-opening for not just myself, but so many people in the dedoc Voices community is having these opportunities to collaborate and to think about different organisations and the work that they do. So for example, I'd love to signpost to Spare a Rose, where if you donate just $5, you can fund someone in a low to middle income country, and you can fund their insulin for a whole month. Things that we would never really think about here when we are doing fundraising efforts for diabetes. And we're very lucky that we don't have to think about that. So that's been kind of what's eye-opening for me, is looking at the different needs that need to be addressed based on the country in question. But I'd love if any previous alumni would like to share their experiences as well. I know, James, you attended ISPAD recently virtually, not to call you out, but to call you out. James is Together Type 1 and a dedoc voice, and it was actually last year at this conference that dedoc had their first experience in the UK and got to meet with Together Type 1, and I just want to say a huge shout out again to DUK for ensuring the lived experience between both groups. It's been incredible, but I don't know if you have any learnings to share from ISPAD, for example, the International Society for Paediatrics and Adolescents. You might just, maybe. Thank you so much.
I think they were talking on the panel there about sort of it was actually your question about the disparities sort of worldwide. So I was sort of going into from the mindset of being from Belfast, and that's usually the only sort of group that I'm working with most of the time. So when I sort of got to attend sessions at ISPAD, it was sort of worldwide. It was data, statistics, lots of different sessions about countries that I've never really had to consider before until then, and I've very quickly learned that I do have it lucky back home, and it sort of makes you want to get more involved in the global space anyway, and that was probably the key takeaway.
Thanks, James. Yeah, and I think what our whole message here today is involving people with diabetes really gets things to move faster. So having people in different parts of the world engaging in different projects and raising more awareness about projects. For example, you can provide $5 for insulin for a whole month. That we can be aware on this side of the world that our cup of coffee costs the same as someone's insulin for a whole month, and being able to engage more in these international efforts to ensure the improvement of the quality of lives of people with diabetes across the world. So yeah, thanks, Jay. Great question. If anyone has anything to add to it or any further questions, I'd love to hear them. I think Mark is going up there.
My name's Mark Tiller. I'm a type 2, I'm a dedoc voice as well. My question is for Bethan. In my personal experience, I burnt out for a long time. I was diagnosed in 1996. In 2019, I made the decision to quit a very stressful job. And in doing so, I chose to prioritise my health. And 4 months after that, I started really actively improving my management of my diabetes. But it took that mental shift prior to starting to manage properly to have the motivation to do that. How important do you think those mental shifts are, and what can we do to encourage more people to make those shifts mentally so that they are in a space to be able to improve their control?
That's a very big question, isn't it? I think most people are doing things because they have to do them financially, and if you're in a situation where you're able to make those changes, then you do. I don't think I could do it justice. I will think about it all afternoon, what you're saying, but all I would say is I know how hard it is, and I would just say what I say to my daughter all the time: if I could take it from you, I would, in the blink of an eye, happily.
Sorry, can I just jump in here? Is that okay? I just wanted to say I have been doing advocacy for the past 10 years, but in those 10 years I did take a 2-year break because I did burn myself out completely. I was sharing my personal lived experience story so much that, which is an extremely personal thing to do, that I just wasn't taking care of my physical or mental health enough. So it took that 2-year break for me to say, okay, I need to approach this differently. I need to first and foremost take care of my own health before I give anything to anyone else. And so thankfully there was like a lockdown, so I could actually like take some space and be okay after that. But it is a big thing to do, and with diabetes we need to make sure that do we have everything we need mentally to deal with advocacy, because sharing such personal stories all the time is not sustainable. And also when we ask people to share their lived experiences, we have to make sure that we are being mindful of that, because I know personally myself, I am a person who says yes, I will do that, even though it's not always healthy for me. So yeah, that's something to be mindful of when we are working with diabetic people or people with diabetes, that is it ethical for me to keep on asking them to share and re-traumatize themselves with the same personal stories? I think that was answering your question.
It does, thank you. I would just like to make one more comment as a type 2. Nobody chooses to have diabetes, and everybody makes the best decisions they can at the time. Nobody deliberately makes a bad decision. So blaming someone with any type of diabetes, but particularly type 2 of their condition, is counterproductive and demeaning when they are making the best decisions they can at the time. They can look back and say, I could have made better decisions, but at the point in time that they were, no, they couldn't. They did the best they could at the time.
Thank you so much, Mark, for an amazing question and an amazing and very, very important message. I think it's just a really, really important one to drive home, and everyone knows this. No one ever asks to be sick or unwell or wants to be. And everyone is always doing their best with the tools that they have, the energy that they have, the resources that they have. And some people are hit with things they don't expect. And it's just really, really important to remember that when people are dealing with any health condition, they're always doing their best. So also, Mark will be speaking at our 8DD symposium in a month in Amsterdam, which will also be live streamed, about his experience with type 2. And Mark is an incredible speaker, as you've just heard from his comments, and the emotion and heart he brings to everything he does. So thank you, Mark, again. Yes, I would love to thank you also for your responses. I know it's a hard question to answer when it comes to talking about mental health and burnout. Speaking from experience myself as well of burnout, it's definitely not an easy one to tackle. So thank you all for amazing answers on the question as well. Are there more questions? Oh, I'm getting signs that there's questions online also. So there is a question for Kirsty regarding the NHS's approach to integrating peer support. So if you have information, Kirsty, to share on who took this initiative to start the programme and how it's funded, and who manages the peer support folks to engage and contribute.
I'm not really sure. I know that there was, I should know that. I know that there was funding given for tech, I think it was in like 2016, I want to say. Did it come from that? Do you know the answer, Jean? Because I don't think I do.
So the team behind it, I can't answer about the team. The team behind it are an amazing group of healthcare workers who are, like all the people in this room, who really want to see lived experience integrated into every part of diabetes care. So there's an amazing team of dietitians and diabetes educators who've driven this whole project forward to make sure it's been happening since last year. It's only 1 year old, so it's very, very young. But it is completely supported by the NHS Golden Jubilee. That's where you can find out more about it. And the programme was called the ANYA project, I believe. So you can research that as well and get more information on it there. But it is a fantastic programme. There's 8 of us in Scotland, 8 peer support workers. And we basically get a list of different groups that are getting onboarded onto their hybrid closed loop systems, and we get to choose which groups we'd like to support based on our own experience with our technology. And the way people are selected was basically the most amazing criteria, which is, do you have lived experience with diabetes, or are you supporting someone with diabetes? And that's been it for the last year, basically. In terms of managing us, they're very much like, you're the experts of this condition. Please just bring that expertise to the calls. And it's a very independent role and a really well-run role.
Yeah, I think the funding for the pumps comes from the 8.8 million, the pumps and sensors predominantly. But I think there was separate funding for setting up the pathway.
I think it might be opposite. I think the 8.8 million funded the ANYA onboarding process, and then other funding happened before. Maybe.
Thank you both. So basically, it's been running for a year with that funding, which is great, and we hope it will continue and be spread across the rest of the UK. It would be amazing to see a lot more people with diabetes involved in this care from the outset.
Can I go now? Sorry, can you hear me? Is that fine? I just had a question. Thank you, I think it was Alyssa, for sharing just that sometimes when you're involved in sharing your lived experience, it can like burn you out or be emotionally exhausting. I kind of have a twofold question. First of all, is there any kind of support or training that you've received when you've been involved in sharing your lived experience? This is for anyone, by the way. Or anything that's been really helpful that either people running focus groups or healthcare professionals could take into consideration and make those groups more accessible for you or others, you know?
I can go for this one. Yeah. So Diabetes Scotland runs speaker training, and whenever I've kind of spoke on behalf of Diabetes Scotland or Diabetes UK, I've always had a kind of one-on-one video call with whoever's asked me to do it, or the people that are running the programme, where they just set out their expectations. I would give them my ideas, and they're really supportive that way. Miss Mary down the front is great at it. Mention me again, sorry.
Yeah, I know when I've been involved in things like the Diabetes Scotland Youth Project or Together Type 1, there's always a youth worker or there's someone available to do a debrief after the session, so make sure that if it is emotionally heavy, there is that forum for someone to check that they're okay afterwards. But I don't think I've had any training. I just think that maybe if you are setting up a process, sit people down and talk about what their personal boundaries are and how to enforce them, because it's something that I never had at the start, and maybe someone like setting out in plain terms like this might be hard. Think about what you can handle might be a good idea.
Thank you.
I would just love to echo what Alyssa said there as well. I think something that can be really nice to kind of help someone shape their answer is to suggest, you know, to think of what they share is as a litmus test. Would they be comfortable with their neighbour knowing this? So, because often when we come to these spaces to share our personal stories about lived experience, and we see it a lot, it's emotional. It is bringing up a lot, like Alyssa mentioned, and sometimes it can be hard to pull back that boundary. So to set that from the start with the person and to make sure that what they are sharing, they're actually comfortable sharing with. I think especially, not so much in research situations, but podcast situations, it can often just feel like a friendly conversation at home, and people forget that it's going to be broadcasted live or shared live, or they might overshare, and then making sure to, if it's something recorded or documented, to share it with the person before it goes live. And then also I think what Alyssa mentioned about the debrief afterwards is really important. Sometimes if there's maybe a heavy topic, to have some form of psychological support available, or to ask if that person would need that after a session of like that. Thank you so much, great question.
That's really helpful, thanks.
Yeah.
I just wanted to add as well on that. So the Inodia Consortium, which is a research consortium of partners that researchers in type 1 diabetes, some people may know about it already, has they call it the Impact Group, which is Patient Advisory Committee. So within each of the trials, core trials, there is a person living with diabetes that represents lived experience on those trials, and at the core group as well. And so one of the key things that was built in 10 years ago when the program set up was to make sure that they have somebody, a mentor to track back to be able to talk to, particularly in the fact that the power dynamic is very shifted, that there is, you know, important research going on, and researchers, people who are very prominent in the diabetes community, with, you know, little old me just sat there giving advice as a person with diabetes. So that it's always hard to be able to engage sometimes in that way. So having someone to track back to, and there's a lot of training and a lot of information which lives within kind of Inodia. And so I would reach out to Anna, who's the coordinator for Impact there, if you're looking for specific resources, because she'll have a wealth of stuff, even a training program, which is now in collaboration with UPETI to do that.
Thanks so much, Shay. Yeah, it's a great resource, and Anna is also a member of Team dedoc. So again, dedoc voice wearing multiple hats, and dedoc team member wearing multiple hats. It's what we do best. Fantastic. Are there any other questions or any online from the back? No? Great. Well, thank you. So, oh, sorry, Mark, do you have a question? We still have a few minutes.
It's not a question, it's more a statement. If you're having a consultation with a diabetic, as the healthcare professional, you are there trying to rationally and calmly pass information to your patient, I can almost guarantee you that they are not having a rational conversation with you. They are having an emotional conversation. The most important and insightful question you can ask them when they first arrive is, how do you feel about your diabetes at the moment? It's not what's your control, it's how do you feel about it. And that will give you a wealth of information that you can use to shape the conversation. So, yeah, find out what their emotional state is before you try to be too rational with them. Thank you.
Thank you so much, Mark. And that is why our symposium is called What We Wish You Knew and Why. I hope you enjoyed all of our incredible speakers. And as Renza, our head of advocacy, always says, thank you for being here and thank you for showing up. And thank you for your attention today. It's been a pleasure.